I'm Dr. David Borenstein. I'm a clinical professor of medicine at the George Washington University, Washington, D.C., and I'm partner at Arthritis and Rheumatism Associates in Washington and Maryland. It's been a very exciting time here at the American College of Rheumatology annual meeting in San Diego, and I've had interest in looking at the back pain abstracts. Though there are only a few, there are a couple that were of particular interest to me at this meeting. One was from actually Toulouse, France, which looked at the inflammatory changes that occur in MRI in people who have back pain, both in the anterior component of the spine as well as the posterior elements. And what they were looking at in these, the majority who were female, was looking to see if there were changes in MRI, both in the anterior component, which is like the vertebral body, and whether the modic changes which occur there were associated with pain, and whether you also found the posterior elements, like the facet joints and the spinous process, whether they were associated with pain, and was there a differentiation. And lo and behold, the answer once again is that there is no specific correlation with what you see and what the patient complains of. So in fact, MRI can show you anatomy, but it does not show functional changes. So you once again need to think very carefully about what the patient complains of and what is on the MRI to see if whether it actually correlates. Because if you just do blind MRIs, you will find changes. Other very interesting abstract in the back pain group was actually a nice study done by the University Hospital in University of Oregon, where they did a study of their patients, over 150, with diffuse idiopathic skeletal hyperostosis. It's a disease that rheumatologists know because many times it's confused with ankylosing spondylitis, but it is a disease we see, and they did a very nice group study of these individuals, and what it ends up is that unfortunately elderly men who are obese seem to be at greatest risk of developing this disease. What's interesting, however, is only about 63% ended up having back pain even though they had characteristic changes of DISH. So DISH may exist in a significant number of individuals who don't really have back pain. So it's something we need to think about in people who may have stiffness. Some of the other things that we find that we usually associate, like diabetes and hypertension and all, weren't necessarily components of what we see with DISH. So once again, I think when we think about this disease, we need to think about it with people who are older, men, who may be overweight, who may be particularly stiff. We should think about DISH. So look at these abstracts, and I think you'll get a very good view of what's happening at the ACR annual meeting in regard to back pain.